Okay, let's unpack this. If you walk into a cosmetic surgery clinic in Miami today, they might actually tell you the G-Shot is only for women who already have a highly active sex life.
Right.
But if you catch a flight to London, a clinic over there will tell you it's designed specifically for women who have never experienced a climax.
It's completely wild.
It really is. So today's deep dive is about how a single anatomical mystery essentially created a booming commercial industry built almost entirely on contradictions.
Yeah, and we are pulling from a massive stack of sources today.
Totally. We have, clinical studies. We have strict guidelines from medical boards like the American College of Obstetricians and Gynecologists ACOG and the NHS.
And of course, a mountain of promotional materials from cosmetic gynecology clinics all over the world.
Exactly.
Yeah.
And our primary mission today is to cut through all that marketing spin to answer one highly specific but surprisingly complex question, which is, who is actually a suitable candidate for this procedure?
What's fascinating here is that before we can even begin to answer that question, we have to navigate this huge maze of medical debates.
Right, because you can't define the candidate without defining the treatment.
Exactly. You cannot accurately define a suitable candidate without first defining what exactly you are treating. We are looking at a space where genuine anatomical ambiguity just straight up collides with high-end cosmetic marketing.
So let's start with the anatomy and the fundamental premise. According to the literature, the Grafenberg spot, the G-spot, is an erogenous zone located about 2 to 3 inches, or roughly 5 to 8 centimeters, inside the anterior vaginal wall.
Right, that front wall.
Yeah. And the mechanical goal of the G-shot, or G-spot amplification, is to inject a specific filler directly into this localized area.
And the clinics in our sources use a few different materials to achieve this. There is human-engineered collagen, which provides structural support.
Okay.
And then there are cross-linked hyaluronic acid fillers, which are actually very similar in composition to the dermal fillers used in facial aesthetics. Oh, like lip filler.
Basically, yeah. Hyaluronic acid is essentially a moisture-binding molecule that creates an immediate, stable gel volume in the tissue.
Got it.
And then there is platelet-rich plasma, or PRP. For that, the clinic draws the patient's own blood and spins it down in a centrifuge to concentrate the platelets and growth factors.
Wait, really? Their own blood?
Yeah, the aim there is to promote local tissue regeneration.
Wow. Okay, so the functional idea behind all these materials is that you inject them and the target spot physically increases in size.
That's the goal.
Right. The promotional materials describe it expanding to the volume of a 1/4 inch, or about a 5p coin. So it thickens the tissue and forces it to project lower into the vaginal canal.
Exactly. By narrowing that internal urethrovaginal space, the procedure alters the sensory feedback loop during intimacy. It just forces more direct contact.
Making it easier to hit, essentially.
Right. The goal is to increase the mechanical friction and pressure that the specific area receives during penetration. But looking through these clinical studies, there is a massive elephant in the room regarding the target area itself.
Oh, the anatomy debate.
Yeah. I mean, we are assuming this spot is a distinct anatomical structure, but the science is genuinely split.
It is the central tension of the entire field. Take the major study from King's College London, led by Professor Tim Spector.
The twins study, right?
Yeah, this was a massive undertaking involving 1,800 pairs of twins. And twin studies are basically the gold standard for separating genetic traits from environmental ones.
Right, nature versus nurture.
Exactly. The researchers hypothesized that if the G-spot is a distinct anatomical organ, like a kidney or a spleen, identical twins should share it.
And their conclusion was that they found zero genetic consistency, right?
Yep, zero. If one identical twin reported having a distinct G-spot, the other wasn't significantly more likely to report it.
Wow. So does that mean it doesn't exist?
Well, that lack of genetic heritability led a significant portion of the scientific community to argue that the G-spot might be a myth, or perhaps a highly subjective sensory experience rather than a universal anatomical structure.
Which is wild.
You also have researchers in our stack like Amitai Kilchevsky who argue there is no distinct evolutionary reason for a separate G-spot to exist at all.
But we also have studies in our stack that push back on that completely. I mean, there is the Rutgers University study that used functional MRI machines to map the female brain during stimulation.
Right. The fMRI data is fascinating. Functional MRIs measure changes in blood oxygenation in the brain, allowing researchers to see which areas become active in real time.
And what do they find?
The Rutgers team found that when the anterior vaginal wall was stimulated, distinct highly specific regions of the sensory cortex lit up.
Wow.
And crucially, those regions were completely separate from the areas that activated during clitoral stimulation.
Oh, so it's not just the same nerve pathway.
Yeah.
Then you add in the ultrasound studies from the University of L'Aquila, which visually demonstrated that women who consistently experience vaginal orgasms actually have physically thicker tissue in that exact urethrovaginal space.
Yeah, the physical thickening seen on those ultrasounds supports the idea that there is a localized, biologically active zone there, even if we are fiercely debating what to call it.
So bringing this back to the core premise of the procedure, if some scientists are saying this is a general region, or perhaps just the internal network of the clitoris,
Which some of our sources actually call the clitorethrovaginal complex.
right, the clitorethrovaginal complex,
Mm-hmm.
we are basically dealing with a network rather than a solitary button. And yet doctors are aiming a needle at a highly specific coordinate.
It's a valid point.
So if I'm understanding this correctly, it sounds a bit like putting a giant red bullseye on a dartboard that might not actually exist. How does a doctor know who to treat if they can't even agree on the anatomy?
Well, the practitioners performing G-Spot amplification argue from a purely functional standpoint.
Okay, how so?
Their stance is that whether this area is a distinct evolutionary gland, a convergence of nerve endings, or just an internal extension of the clitoris, the anterior wall is undeniably highly sensitive for many women.
Right.
Therefore, mechanically increasing the volume of that tissue will inevitably increase the friction it receives, regardless of the underlying anatomical label.
Here's where it gets really interesting, because this underlying anatomical uncertainty trickles down directly into the clinics, and it creates wildly different philosophies on who should actually get the procedure.
Oh, totally.
When you look at how different medical providers define their ideal candidate, you are looking at a landscape of absolute contradictions.
The criteria shift dramatically depending on the specific clinic's theory of sexual function.
Let's map out these contradictions because they're pretty stark. We have what I'll call the enhancement candidate.
Okay.
Look at Rodenberg Plastic Surgery in Miami. Their promotional material claims the perfect candidate is a woman who is already fully capable of achieving a vaginal orgasm.
Right, so she already has function.
Exactly. But she simply wants an extra stunning experience or more frequent climaxes. And the American Society of Plastic Surgeons, the ASPS, backs this up.
Right, their official stance is that for a woman who has never achieved an orgasm, these injections are unlikely to help.
Which makes sense.
Viewing the procedure purely as an amplifier of existing function makes logical sense if you believe the physical pathways must already be active for the extra volume to make a difference.
But then you cross the ocean to the Center for Surgery in London. They explicitly state that the ideal patients are those who have developed a loss of vaginal sensitivity and may never have experienced a sexual climax or vaginal orgasm.
That is a complete 180-degree turn from the ASPS guideline.
It is. It's totally opposite.
They are approaching it from a restoration perspective. They are operating on the theory that the lack of climax is due to insufficient physical contact and that adding volume will bridge that mechanical gap.
And just to add a third conflicting perspective, we have clinics like Dr. S.W. Clinics in London. They describe what I'd call a baseline candidate.
Right, the baseline approach.
They state that candidates need to have normal or near normal sexual function before even considering the shot.
Which means
If a patient comes in struggling with vaginal dryness or painful intercourse dyspareunia or female sexual arousal disorder, those complex issues have to be addressed and managed first.
they're viewing the G-shot as the final optional polish on an already healthy system rather than a primary treatment for dysfunction.
That puts you, the listener, in a really confusing position if you are trying to research this for yourself.
Absolutely.
I mean, if Clinic A says this is strictly for women who can already orgasm, and Clinic B says it's practically a cure for women who can't, it's like being told a specialized sports drink is exclusively for professional athletes, but the label insists it's designed to help couch potatoes run a marathon.
That's a great way to put it. To find any sort of reliable consensus in that chaos, you really have to strip away the marketing and look purely at the mechanism of action.
What it actually does.
Exactly. What is the G-shot biologically doing? It is a mechanical augmentation. It is creating a physical protrusion to increase friction against a mucosal wall.
Right.
It is not altering hormones, it is not repairing severed nerves, and it is not treating psychological blocks.
So if a woman's inability to climax is rooted in a severe hormonal imbalance or, deep relationship trauma, adding a hyaluronic acid filler to the vaginal wall will not address the root cause.
Not at all.
It's a physical modification, not a functional cure-all. If the wiring in your house is faulty, changing the shape of the light switch won't suddenly turn on the light.
The most objective consensus we can draw from the clinical side of our sources is that the most suitable candidate is someone with a healthy, established baseline of sexual function who is specifically seeking a localized mechanical enhancement of sensation.
Because the ideal candidate is so wildly subjective depending on which clinic's marketing material you read, the major medical boards have essentially bypassed that debate entirely, haven't they?
Yeah, they really have.
Instead of trying to define who should get this procedure, they've built incredibly strict walls around who absolutely should not. This is where we shift from subjective enhancement goals to objective clinical safety.
The hard disqualifications are where we finally see total agreement across all the medical literature.
What are the absolute hard no's?
There are absolute medical contraindications where any reputable doctor must deny the procedure. The Women's Health Clinic lists these as active pelvic or vaginal infections, any undiagnosed vaginal bleeding, active lesions, and pregnancy or breastfeeding.
Okay, those make perfect sense. But beyond those absolute barriers, the sources detail several relative contraindications that require deep scrutiny too.
Yes, blood or clotting disorders are a major red flag, particularly if a patient is considering the PRP version of the shot.
Right, because of the blood draw.
Exactly. Because the PRP process involves drawing blood and spinning it down to isolate and highly concentrate the platelets, which are the body's primary clotting agents, injecting that highly concentrated material into a highly vascular area of someone with a systemic clotting disorder is a recipe for a severe localized complication.
Yikes.
Also, autoimmune issues or having had any genital surgery within the last 6 months also mandate waiting or seeking alternative therapies.
And looking at the anatomical mechanics of this, if the pelvic floor is already structurally compromised, like with severe pelvic organ prolapse, injecting a filler seems like putting a Band-Aid on a broken beam.
That's exactly what it is. The underlying architecture is giving way, so a superficial bump in volume isn't going to hold anything up.
So they wouldn't be candidates either.
Right. The structural integrity of the pelvic floor is a critical factor. Patients with grade 3 or 4 pelvic organ prolapse, where the organs have dropped significantly due to weakened musculature, require structural surgical repair.
Injecting a soft tissue filler into a collapsing vaginal wall is applying the completely wrong medical tool to a structural crisis.
Exactly. And the guidelines also highlight a fascinating and deeply important layer of disqualifications, the psychological screening.
Oh, right. The American Board of Cosmetic Gynecology, the ABCG and ACOG, both strongly advise psychological readiness screening prior to any cosmetic genital procedure.
Yes. Providers are explicitly instructed to screen patients for body dysmorphic disorder, a history of sexual trauma, or wildly unrealistic expectations.
Which is so crucial.
It is. Because cosmetic gynecology is expanding so rapidly, there is a documented risk that vulnerable patients might seek out these physical procedures, hoping they will act as a magic wand for deeply rooted emotional distress or fracturing relationships.
That ties directly into a massive misconception about libido that our sources continually warn against. The procedure cannot fix low libido if it's caused by outside factors.
Libido is incredibly complex.
Right? It's rooted in the brain and the hormonal system. If your desire is low because you're taking SSRI, antidepressants, or dealing with a non-sexual disease like arthritis or high blood pressure.
Or simply navigating the chronic fatigue of daily life.
Yeah, exactly. A mechanical injection in the vaginal wall won't change your brain chemistry. It sounds like a lot of women might seek this out, hoping for a magic fix to a much deeper issue.
Arousal and desire are complex, multi-system processes.
It's like trying to fix a software glitch by buying a new computer mouse. If the issue is stress or medication-induced, the hardware isn't the problem.
That is a perfect analogy. The hardware isn't the source.
So, knowing how complex these underlying issues are, how does a doctor actually weed out these underlying issues in a clinical setting? I mean, a proper consultation shouldn't just be pointing at a menu of aesthetic services and handing over a credit card.
A rigorous consultation is the ultimate safety net. It requires a comprehensive evaluation of the patient's medical history, current sexual function, and psychological state. And the cornerstone of that process is the consent framework.
The ABCG highlights a specific legal and ethical framework for this, called the Montgomery Standard.
Right. The Montgomery Standard represents a massive shift in medical law from the old doctor knows best model to a much more patient-centered risk analysis.
What does that actually mean for the patient?
It dictates that a doctor cannot just hand over a generic, pre-printed list of risks. They must actively discuss the specific risks that matter to your unique lifestyle and medical history.
And we have to highlight a crucial detail from ACOG here. The American College of Obstetricians and Gynecologists explicitly states that this procedure is not medically indicated and currently lacks high-quality peer-reviewed data to support its long-term effectiveness.
Yes, and because of that lack of robust, long-term clinical data, standard surgical consent forms are actually deemed insufficient. Clinics following best practices must use upgraded consent forms. These documents have to explicitly state to the patient that there is a lack of widespread clinical evidence.
So they have to be totally upfront about the unknowns.
Exactly. They must detail known risks like localized infection, bleeding, altered or lost sensation, and dyspareunia, and they must also clearly acknowledge the unknown risks. The patient has to be fully aware that they are stepping into a space where the long-term scientific consensus is still catching up to the commercial application.
That is a level of radical transparency that you don't exactly see advertised on clinic Instagram pages.
No, you definitely don't.
So beyond the upgraded consent, what else marks a responsible ethical consultation?
A mandatory cooling-off period.
Okay, what's that?
Clinics that adhere to the strict guidelines from the General Medical Council, the GMC, or the Royal College of Obstetricians and Gynecologists implement a forced reflection period for elective genital procedures.
Meaning you can't just get it done right then and there.
Right. You attend your consultation, you receive all the medical and risk information, and then you leave. You go home to process it. You should never be pressured into receiving the injection on the same day as your initial consultation.
It prevents impulse decisions regarding deeply intimate health.
Exactly. Furthermore, the UK's NHS provides an excellent checklist for vetting the provider themselves. You need to ask highly specific questions during that consultation.
Like what?
Who is prescribing the treatment, and is that the exact same person who will be injecting you? What is the specific brand name of the product being used?
Right, because there's so many different fillers.
Are they using cross-linked hyaluronic acid, or are they processing your own blood for autologous PRP? You have an absolute right to know the precise chemical or biological makeup of what is going into your tissue.
And the NHS checklist also outlines some severe red flags to watch out for.
They strongly advise against group treatment scenarios or promotional G-Shot parties where alcohol is served.
Wait, G-Shot parties? That sounds like a disaster waiting to happen.
It is. They also warn patients away from practitioners who rely solely on social media to advertise, or mobile services offering to perform the procedure in hotels or private homes.
Wow.
Injecting filler into highly vascular mucosal tissue is a serious medical procedure carrying real infection risks. It requires a sterile, heavily regulated clinical environment and a registered medical professional equipped to handle immediate complications.
So what does this all mean for you, the listener? It means you have to be your own fiercely protective advocate. If you walk into a clinic and they promise you the moon or guarantee multiple orgasms without ever asking about your medical history, your mental health, or if they offer to do it right then and there without a cooling off period, that's a massive immediate red flag.
If we connect this to the bigger picture, a responsible consultation is a partnership of shared decision-making.
Right.
The practitioner's job isn't just to locate a coordinate on the vaginal wall and deploy a syringe. Their fundamental job is to evaluate your holistic health.
Which means looking at everything.
Exactly. They need to consider everything from your hormonal balance and your pelvic floor architecture to your relationship dynamics and emotional well-being. The G-Shot is merely one highly specific, highly debated tool in a very expansive toolbox of sexual wellness.
Let's bring all of this together. We started with the mission of answering who is actually a suitable candidate for G-Spot amplification. And what we've uncovered is that the answer requires navigating a total minefield of nuance.
Yeah, you have cosmetic clinics suggesting it's for virtually anyone desiring a boost, while the major medical boards point out the glaring lack of clinical evidence and warn heavily against viewing it as a functional cure.
So distilling all the clinical data, the consensus on an ideal candidate, if one even exists, is a healthy woman with realistic expectations, who understands the ongoing anatomical debate, has no underlying medical, structural, or psychological issues preventing arousal, and is specifically seeking a temporary mechanical enhancement of tissue volume.
Perfectly said. And it is firmly not for individuals seeking to cure deep-rooted medical, hormonal, or psychological dysfunctions.
Right.
Exploring your intimate health and seeking out ways to enhance your sexual wellness is a vital part of overall well-being. But being a good candidate means arming yourself with objective facts.
You really have to do the homework.
It means asking tough, specific questions about the products being used, demanding rigorous safety standards and sterile environments from your provider, and deeply understanding the mechanical limitations of the procedure itself.
Before we wrap up, I want to leave you with one final unexamined idea to ponder. As we were researching the history of the G-Shot and how it fundamentally relies on mechanically stuffing a specific anatomical spot with physical filler to create friction, we also started looking at the horizon of regenerative medicine.
Oh, yes. The field is evolving at an incredible pace.
We're seeing investigational treatments entering the sexual wellness space, utilizing things like exosomes.
Exosomes are fascinating.
Yeah. Instead of just adding inert physical volume, exosomes involve delivering highly concentrated cellular messengers. These are essentially packets of biological information, RNA and proteins, that send specific signals to your existing cells, instructing them to upregulate repair processes at the DNA level and significantly reduce local inflammation.
It represents a massive shift from a purely mechanical, architectural fix to a functional biological one.
So the provocative question is this. As these advanced regenerative therapies evolve, will the very concept of amplifying or mechanically inflating a specific coordinate in the body eventually seem completely outdated?
That's a great question.
Could the future of sexual wellness be less about altering the shape of our anatomy to force more friction and more about teaching our existing cells to heal, communicate, and function exactly like they used to?
It definitely has the potential to change the entire paradigm of how we view both intimacy and the biology of aging.
It's like realizing that instead of trying to build a luxury theme park on an island that might not even exist, we could just focus our energy on making the entire ocean healthier.
Wow, I love that.
Thank you for taking this deep dive with us. Keep asking those tough questions, keep advocating for your own health, and we'll see you next time.